last video, we have discussed about the limiting structures of the maxillary arch. Now let's talk about the supporting structures or the stress-bearing areas in the maxilla. The knowledge of the landmark is necessary for the maximum support, retention and the denture base extension without interfering the health or the function of the tissues. Before we learn about the supporting structures, let's understand what a support is. A support is the resistance to the displacement towards the basal tissue or the underlying structures. And the supporting structures are those areas of the maxilla and the mandible, edentulous ridges that are considered best suited to carry the forces of mastication when the dentures are in function. The supporting structures are the stress-bearing areas, and they can be primary stress-bearing or secondary stress-bearing areas. Coming to the primary stress-bearing areas. These are areas that are at right angles to the occlusal forces and usually do not resorb easily. They are lined with grayish pink mucosa which is dense, keratinized and have minimal vascularity. For example, the hard palate on either side of the mid-palatine raphe is a primary stress-bearing area. Coming to the secondary stress-bearing areas. These are areas that are at greater than right angles to the occlusal force or are parallel to them, and areas of ridges that are at right angles to the occlusal forces but tend to resorb under the load, like the anterior ridge and the ridge slopes. They appear deep pink due to increased vascularity. Examples of secondary stress-bearing areas are the palatine rugae and the maxillary alveolar ridge. Coming to mucous membrane. The bone of upper and lower edentulous jaws and of the oral cavity is lined with a soft tissue that is known as the mucous membrane. Denture bases rest on the mucous membrane, which serves as a cushion between denture base and the supporting bone. The mucous membrane is composed of mucosa and the submucosa. The foundation for the dentures is made up of the hard palate and the residual ridge covered by mucous membrane. The denture base rests on the mucous membrane, which serves as a cushion between the base and the supporting bone. This picture shows how the mucosa and submucosa of the mucous membrane, the adipose tissue and the compact bone appears microscopically. Coming to mucosa. Mucosa is formed by stratified squamous epithelial cells which is often keratinized. There is subjacent narrow layer of connecting tissue to the mucosa known as lamina propria. In edentulous patients, the mucosa covering the hard palate, crest of residual ridge and the residual attached gingiva is classified as masticatory mucosa. The epithelium is a keratinized stratified squamous epithelium which is with a lamina propria that is thick and dense. Some parts of the masticatory mucosa are without a distinct submucosal layer, yet dense collective tissue of the lamina propria firmly binds the mucosa to underlying periosteum. Although not as effective in providing resiliency, this connective tissue layer serves as a protective base for the mucosa. Next is the submucosa. Submucosa is formed by the connective tissue and varies in character from dense to loose areolar tissue and also varies considerably in thickness. It may contain glandular, fat or muscle cells. In picture, you can see the blood vessels and the nerves present in the submucosa. Submucosa transmit the blood and nerves supply to the mucosa. It attaches mucosa to the periosteal covering of the bone. Clinical significance. When the submucosal layer is loosely attached to the periosteum or it is inflamed or edematous, the stability and support of the denture is adversely affected. Apart from the obvious local and systemic diseases that affect the integrity of oral mucous membrane, the most common general age change seen in elderly patients is a nodular varicose enlargement of the veins on the ventral surface of the tongue, which is also known as a caviar tongue. Coming to hard palate. The ultimate support for a maxillary denture is attained from the bone of two maxilla and the palatine bone. The horizontal portion of hard palate lateral to midline is the primary supporting area for a denture. According to the prosthetic treatments for the edentulous patients by Zaab and Bolender, the bone is subject to resorption, which limits its potential for support, unlike the palate, which is resistant to resorption. Because of this, the ridge crest looked on as a secondary supporting area rather than the primary supporting area. The picture shows various anatomic regions providing support. The primary stress bearing areas and the secondary stress bearing areas, and the R shows the relief areas in the picture. The primary support areas should include the horizontal, anterior and the posterior lateral hard palate. The ridge crest should function at best as a secondary support area, and the midline suture normally requires slight relief, while denture borders is non-contributing in this factor like support. Next is the shapes of hard palate. Hard palate can be square to gently rounded, tapering or V-shaped, and the flat palate. When we view from the backside of a cast, we can see the shape of the palate. So, in this, we can see the square to gently rounded. This is most favorable kind for retention and stability, because the center of the palate presents an almost flat horizontal area, and this will aid in retention. The roomy sulcus allows for the development of good peripheral seal. Tapering or V-shaped. This is less favorable for retention and stability because associated with the thick bulky ridges. So the area for support is getting reduced in this kind of patients. The force of adhesion and cohesion are not at the right angles to the surface when counteracting the normal displacing forces of gravity. The main factors for retention is adhesion and cohesion plays an important role in the retention of the dentures. Flat palate with small ridges. Flat palate with small ridges are the most unfavorable form because the ill-developed ridges do not resist lateral and anterior-posterior movement of the denture. Shallow sulcus do not form a good peripheral seal. Coming to the microscopic features of the hard palate. Hard palate is covered by soft tissue of varying thickness, even though the epithelium is keratinized throughout. In the region of mid-palatine suture, the mucosal layer is practically in contact with the underlying bone and is non-resilient. So the soft tissue overlying it should be relieved to avoid trauma from the denture. The anterior lateral part. The green arrow shows the adipose tissue. The anterior lateral part area has a submucosa that contains the adipose tissue. The posterior lateral zone has a submucosa filled with the palatal salivary gland tissue. The green arrow shows the palatal salivary gland tissues. Next is the residual alveolar ridge. It is a portion of the alveolar ridge and its soft tissue covering which remains following the removal of the teeth. That means the residue of the alveolar ridge. that is a residual alveolar ridge. The size, shape and the ultimate form of a alveolar ridge are dependent on the variation in bone size and its degree of calcification in individuals. Teeth show wide individual variation in size. Large teeth are supported by bulky ridges and smaller teeth are supported by the narrow ones. The amount of bone lost prior to extraction of teeth is an important factor. Whether the extraction was traumatic or whether it was removed easily, all those are important, because the amount of bone lost during extraction plays an important role in the residual ridge formation. The amount of alveolar process removed during extraction of the teeth gives you a depression, this makes the ridge rounded, smooth, or all such factors are depending on the extraction of the teeth. The rate and the degree of resorption. The effect of previous denture. The effect of previous denture in that the ill-fitting denture or dentures with occluding natural teeth may cause rapid resorption of the alveolar process in the areas where they can cause pressure or lateral stresses. The relative length of time for which different parts of jaw has been edentulous. Like when the teeth is there is no teeth in the anterior region for a longer time, or only the anterior teeth were present and the posterior has been lost for a longer time, all those factors have an important role in the resorption of the ridge and the shape of the ridge. Next is the person's general health. Systemic factors always have a very good impact on the residual ridge formation. Coming to the size of the residual alveolar ridge, it can be large, medium or small. Large. The first picture shows how a large residual alveolar ridge looks like. Next is the medium, and the third one shows you the smaller one. Arch forms. This plays an important role in support of the denture and the tooth selection. House has classified arch forms as square, tapering or ovoid, that is class 1, 2 and 3. First picture shows in the cast how the arch looks like, that is class 1 is square, class 2 the tapering and class 3 is ovoid. Okay. It can be the shape of the alveolar ridge can be smooth, irregular, knife edge or flat. First shows the smooth one, how it looks, how it appears, smooth rounded ridges. Then the next is the irregular. Irregular ridges are formed when there are after extraction, when they don't round off the bony spicules and everything. Okay. Then the knife edge. Knife edge is after the resorption for a longer time. And the fourth one shows you how a flat ridge appears. And next is the ridge contour. Ridge contour given by Winkler. It can be high ridge with flat crest and nearly parallel sides. Then it could be flat ridge and knife edge or the V-shaped. The same you could see in the last pictures. Coming to the microscopic structures of residual alveolar ridge. The mucous membrane covering the crest of alveolar ridge is firmly attached to the periosteum of the bone by connective tissue of the submucosa. The epithelium is stratified squamous type, which is thickly keratinized. Submucosa is devoid of fat or glandular cells and is characterized by dense collagenous fibers. The submucosa is relatively thin in comparison with the other parts of the mouth, still sufficiently thick to provide adequate resiliency to the support of the denture. This picture shows the keratinization with dense collagenous fibers. Next structure is the palatine rugae. Rugae are the raised areas of dense connective tissue radiating from the median suture in the anterior one-third of the palate. It consists of series of ridges in the anterior part of the hard palate. In the area of the rugae, the palate is set at an angle to the residual ridge and is rather thinly covered by soft tissue. This area contributes to the stress-bearing role as well as in the retention, although in a secondary capacity. This is a secondary stress-bearing area. Rugae. The arrow shows the small elevated portions. If you feel with your tongue in the anterior part of your palate, you can feel that rugae, the small elevations. That is the palatine rugae. This plays a very important role in the speech, the clarity of the speech. When you make a complete denture, you have to take care of the palatine rugae shapes and mimic the same in the denture so that the patient will have clarity while they talk. Coming to its clinical significance, it resists forward movement of the denture. It should be recorded without pressure. If it distorts while making impression, it can rebound and unseat the denture. These folds of mucosa play an important role in speech, so dentures should reproduce this contour, making it very comfortable for the patient. Coming to maxillary tuberosity. Maxillary tuberosity represents most distal portion of maxillary alveolar ridge. It is considered as one of the most important areas of support because they are least likely to resorb. In upper denture, the tuberosity region is the actual trouble-free zone. This is mainly because of the nature of attachment of muscle fibers. The muscle fibers are attached parallel to the ridge crest. Therefore, the maximum upper extension or depth can be obtained in the maxillary tuberosity region, helping for the retention and the stability of the denture. However, the thickness in this region is very critical because of the close proximity of the coronoid process. During opening movement, the coronoid process comes medially and anteriorly. If the denture is very thick in this region, it will interfere with the movement of the mandible, mainly the protrusive and the lateral movements. The peripheral molding should be done carefully by asking the patient to open mouth widely and do the side-to-side movements. The tuberosity region often hangs abnormally low when the maxillary posterior teeth are retained after the mandibular molars are lost and not replaced for a longer time. The maxillary teeth extrude and brings the tuberosity with them. The picture shows a low hanging tuberosity which is due to a long time retaining of the maxillary teeth without replacing the mandibular lower molars. Most often tuberosity enlargements are only fibrous in nature. Clinical significance. Often the low hanging tuberosity prevent the proper location of the occlusal plane. In either case, the invasion of interalveolar space in the tuberosity area may prevent the posterior extension of the denture. Large redundant maxillary tuberosities are seen occasionally. Often this will result in a combination syndrome. The combination syndrome is also known as an anterior hyperfunction syndrome and was described by Kelly in 1972. These include loss of bone from the anterior portion of the maxillary alveolar ridge, overgrowth of the tuberosities, papillary hyperplasia of the mucosa of hard palate, and extrusion of mandibular teeth. Let's talk about the classification and different case scenarios of combination syndrome in our later videos.